Ladies and gentlemen, dear friends, on this Sunday evening, today we are going to talk about secondary failure of beta cells in type 2 diabetes. We'll try to understand that if we really need to do something different and what are the benefits of combination therapy in type 2 diabetes to begin with. So, we'll try to understand why do we need combination therapy, what is beta cell failure, how does this happen, what is lack of durability of sulfonylurea, beta cell exhaustion, and other concerns. So the conventional therapy, the way we have been treating diabetes, let us review that. The clinical course of type 2 diabetes is characterized by gradual decline in beta cell functions, and sulfonylurea exert their glucose lowering action by stimulating insulin secretion via pancreatic beta cells. So once insulin is released by if action of the sulfonylurea on the pancreatic beta cell, there is effective controlling of blood glucose level. However, over the time, secondary sulfonylurea failure occurs. The beta cell has been failing already because of the diabetes pathophysiology. Now, over the time, those beta cell, the action of sulfonylureas were mediated through them. There is gradual decline, and thus that leads to ineffectiveness of sulfonylurea. And that's why we see that when we use sulfonylurea in treatment of type 2 diabetes, there is lack of durability. That is reduced effectiveness in controlling blood glucose level by the same drug which was giving good control earlier. So let us try to understand what are the predictors of sulfonylurea failure or secondary beta cell failure. So this was reported based on almost 800 patients included in the trial, and several factors were studied, which included fasting plasma glucose level, HbA1c level, and what was it seen, and then basal disposition index is another thing that we'll try to understand. Now you see, depending upon the baseline fasting blood sugar level and HbA1c level, if baseline HbA1c level was more than 8.7%, secondary failure rate was 48.5. Same was if fasting plasma glucose level was more than 10, then secondary failure rate was around 60%. So to say, poorer is the control at the baseline or higher is the blood glucose level, increased is the incidence of secondary beta cell failure. Then comes basal disposition index, that is also associated with beta cell failure. So the results that we do have that suggest higher fasting plasma glucose level, higher HbA1c level, and global disposition rate is associated with secondary sulfonylurea failure. Now there are few lesions which were learned from UK-PDS trial. What did we learn? We all know that UK-PDS trial did have three arms. One was conventional treatment arm, in which only diet and lifestyle modification was given. There was another arm which received oral anti-diabetic drug including metformin or sulfonylurea, and then there was insulin drug also. And it was seen that if glucose control was not adequate with one drug in the intensive treatment arm, second drug was to be added. And what it was seen? With these drugs, oral drugs, after an initial drop of HbA1c, sulfonylurea treated patient experienced a progressive deterioration in glycemic control that paralleled the rise in HbA1c in conventionally treated arm. By 3 years, up to 50% of the diabetic patients required an additional pharmacological agent to maintain HbA1c less than 7%. So that is what we do have. Whatever oral anti-diabetic drug that you use, once you use it one by one, up to 50% of the patient would require second oral anti-diabetic drug. and that is what we call beta cell exhaustion with sulfonylurea. Sulfonylurea did not seem to exert any protective effect on beta cell in newly diagnosed type 2 patient over 15 years of study duration. HOMA-B measurement, that is measurement of function of beta cell secretion. So HOMA-B measurement demonstrated that a relentless rise in HbA1c observed with sulfonylurea resulted from a progressive decline in beta cell function. However, combination therapy of metformin and sulfonylurea resulted in progressive decline in beta cell function. That is what we got from UK PDS trial. There are some other concerns related with sulfonylurea therapy. We all know, apart from lack of durability, which we all have been talking about. There is 74% increased risk of overall monotherapy failure over a period of 5 years with sulfonylurea. Sulfonylurea fails to achieve glycemic durability, and therefore there is a need of durable treatment with newer anti-diabetic drug. Beta cell exhaustion with sulfonylurea makes it difficult to achieve long-term glycemic control. We all know complications of diabetes depend upon how smoothly the blood glucose level have been controlled. But secondary failure of sulfonylurea usually increase in blood glucose level once again after long-term treatment, that is 6 months. These are the basic causes, and if we try to evaluate the mechanism of or probable causative factors of beta cell function, that could be long time overstimulation of beta cell with sulfonylurea, increasing beta cell defect as a pathophysiology, and increasing insulin resistance apart from glucotoxicity. This is a beautiful graph which was shown by my previous speaker also. Decline in beta cell function with sulfonylurea is shown there as a red line when we see this steady decline. The beta cell function declines over the year irrespective of treatment with metformin and sulfonylurea. And this recurrent failure because of patient is allowed to become hyperglycemic before the next step is considered. So the traditional approach, in which we firstly go for lifestyle modification, then go for monotherapy, then dual therapy, then triple therapy, we allow the patient to go in failure before adding the next step. Thus, the patient's blood sugar has got a roller coaster appearance and a roller coaster trip, and that leads to substantial exposure of glycemia to the patient, which ultimately culminates into poor long-term complications. The other concerns that we do have with sulfonylurea as monotherapy can initially control the blood glucose level, but subsequently becomes ineffective and must be replaced or added with insulin. We know the concerns of weight gain, hypoglycemia, and mortality risk with the use of sulfonylurea. So what is the need of the hour? We have been discussing all these things just to find out what is the problem. We have seen that when we treat a patient of type 2 diabetes, we need a therapy which provides efficacy along with better long-term glycemic control and beta cell preservation. And here we do have some evidence from the Verify trial in which combination of DPP-4 inhibitor along with metformin early in the disease course have given beautiful long-term and durable glycemic control. So DPP-4 inhibitor like vildagliptin provides a similar efficacy as sulfonylurea along with better long-term glycemic control, better beta cell preservation, and this is based on clinical evidence. So glycemic parameters which were evaluated: HbA1c, fasting plasma, postprandial plasma glucose level, its effect on HbA1c. Let us compare it with the other drugs. You can see the effect on HbA1c when we combine vildagliptin with metformin is as good as when glimepiride and metformin is combined. So in both group, similar HbA1c reduction from the baseline was seen in 3 months. So when it is told that, well, glimepiride acts faster, when it is told that quicker HbA1c control is achieved by glimepiride, this is what the data says. At the end of 3 months, you can see HbA1c reduction by both these combination were similar. Then effect on fasting plasma glucose level. You can see vildagliptin and metformin compared to sulfonylurea achieved similar reduction in fasting plasma glucose level at 3 months. Postprandial plasma glucose level were also reduced in similar manner. So labeling vildagliptin metformin combination as a weaker combination in comparison to sulfonylurea and metformin was ruled out. Both these group had similar reduction. Now comes the difference. The difference is effect on long-term glycemic durability with vildagliptin. Better glycemic durability with vildagliptin was seen compared to sulfonylurea in age study. This age study showed that there is 5 times lower rate of loss of function, that is less pronounced HbA1c drop with increasing disease duration for every year with vildagliptin compared to sulfonylurea. You can see the graph. Vildagliptin demonstrated less dependency on duration of type 2 diabetes, whereas effectiveness of sulfonylurea diminished faster with increasing duration of disease. The verified trial that I told you, it gave us the conclusion that better glycemic durability is seen with vildagliptin and metformin early combination in comparison to initial monotherapy. Beautiful to understand. I am using same 2 drugs. In one group, I am using combination of this drug since diagnosis. In another group, I am using one of these drugs and add second drug when the first drug fails. And then we try to see that how much time does it take for tertiary failure. So both these drugs, how much time will it fail? So it was seen that there was 49% reduction in risk of time for initial treatment failure with vildagliptin metformin early combination when compared to monotherapy. So that is well accepted or well expected, that when I use 2 drugs together, its failure would be less, and there was 49% reduction in risk of time to initial treatment failure when both these drugs were used together. Medial time to loss of glycemic control was nearly doubled with combination therapy. Let me give you some example. If monotherapy fails in 2 years, if I have started patient on dual therapy, his glycemic control will stay there for 4 years, and that glycemic control will be very good, and we are preventing the roster collar trip of the patient. Now let us move to another aspect. In one group, I have given 2 drugs to begin with. In another group, I added the second drug when first drug failed. What is the result? Now I should be expecting that when both these drugs are being given in both the arms, the time to tertiary failure should be reduced. But it was not like that. In those arms which received combination therapy to begin with, secondary failure was later in comparison to those arms who received 2 treatment sequentially adding one to the other. That is to say, if you combine treatment early in type 2 diabetes, particularly vildagliptin and metformin, durability of the response is increased, and there is 26% reduction in risk of time to second treatment failure with early combination therapy compared to initial metformin monotherapy being added with vildagliptin after primary failure. So effect on beta cell function in newly diagnosed type 2 patient with vildagliptin. So these are some and sub analysis from verified trial where you can see the effect on HOMA B. HOMA B was improved with combination therapy. So I would like to conclude my talk here. Sulfonylurea are associated with lack of durability and secondary failure of beta cell function. Vildagliptin ensures similar efficacy as sulfonylurea. It has better long-term glycemic durability. It preserves beta cell function, and thus it is a complete holistic management of type 2 diabetes, and it should be started early in the course of disease. Thank you very much for your patient hearing.
Thank you so much, sir, for taking us through for such a beautiful presentation, sir. And now, sir, we have some